transplant program at RWJ Barnabas Health, the Northern Division. What I'd like to discuss today are the newer events that have occurred in the field of transplant and mechanical support. A lot's been happening recently. Mechanical support has certainly come to front and center in the face of COVID last year. But to begin with transplant, we have a very large program here. As some of you might have heard, a couple of years ago, we reached a milestone, 1,000 heart transplants. We've currently done over 1,100, and there are only about 12 or 13 programs in the country that are that large. Something that we do that not most programs do is we do a fair number of high-risk patients, older patients, patients with various types of cardiac disorders that were previously not treated with transplant. One of those was a couple of years ago in December 2018. We transplanted the football player, Matt Millen, who's won 4 Super Bowls, and he actually made his story public. ESPN did a story about him to highlight the fact that he had a disease that was previously not treated by transplant, amyloid. And we have a fairly big amyloid center here. We follow quite a few patients, and we transplanted several with, thankfully, very good outcomes. I mentioned high-risk cases. That is something that we and some other large programs have been able to do because we have a very large multidisciplinary program here that can take on these kinds of very complex cases. And finally, unlike most programs in the country, we do take care of older patients. 65 years of age is the common cutoff age for transplant around the country. We actually don't have a formal cutoff above mid-70s, and we carefully select patients in their 70s, some of whom were transplanted and are doing very well, some of whom are still on our list and are ready to be transplanted. Again, we select them very carefully if they're in very good shape and otherwise have the robust makeup of someone in their 60s. We don't see any reason not to transplant them. To support this kind of scope of services in transplant, we have a huge team I have to give credit to. It's because I stand on their shoulders that we're really able to deliver this care to such a wide variety of patients. In the transplant world, 2 recent developments are the quote, heart in a box. In about 10 years ago, we were one of the first programs to trial this, in clinical trials. There are 7 programs that basically trialed a method of preserving a heart from the time it left the donor hospital to the time it came to the recipient hospital. And as most of you know, the way to preserve organs commonly after procurement is to put them on ice in a cooler. Well, for this, we are able to attach it to a machine, the heart. We connect it to a machine that pumps blood through the heart and allows it to keep beating during the transport. The device will probably be FDA approved sometime this year, but one very important thing it does is it decreases the time that the heart is not beating outside the body. And so that preserves the heart really very well and is the best way of preservation. And so if we are able to do this, we can travel longer distances to procure hearts if necessary. And what that will do is hopefully increase the donor pool. Because after all, that is what restricts the number of transplants we do in the United States and around the world. There are about 6 million patients in the US with heart failure. At least 250,000 are so severely debilitated that they would benefit from a transplant or some sort of mechanical support for the heart. So we have 250,000 of patients who really need that kind of therapy. And in this country, we can do no more than about 3,200, just a little over 1%, 3,200 transplants a year. And that's been true for the last 30 years because of donor shortage. So if we're able to increase the donor pool, then that should really enable us to help that many more patients. Another development that began in several centers, such as the Brigham, was to accept donor hearts from hepatitis C positive patients. Because, as you know, several years ago, a very good cure, so to speak, was developed for hepatitis C. It's oral, depending on which drug you take, it's 1 to 3 months of therapy. And prior to the days of hepatitis C therapy, we would not be able to accept hearts from hepatitis C donors because if our recipients contracted the disease, there was really no very effective cure for a lot of people with Hep C. But now that's different. And so most programs across the United States, especially the bigger ones, do accept hepatitis C donors. And if our recipients seroconvert and contract the disease, they're easily treated. To my knowledge, this has been going on now for, I want to say, at least 4 or 5 years. And to my knowledge, I believe there have been no deaths from people who seroconverted to hepatitis C because the treatments have been so effective. Another way to treat heart failure, and probably a more common way, which is available in more centers, is to provide mechanical support for the heart. And so we've had a big program here at New York Beth for the last 20, 25 years. We've been involved in just about every FDA clinical trial for these advanced devices. One thing that's great about that is that we're actually able to offer this technological therapy to patients before it becomes FDA approved and appears on the shelf. And so I can tell you from my own anecdotal experience that because we have been involved in these trials, I've been able to save so many more lives because I was able to offer these advanced pumps, before they became available to most centers. The mechanical support is 2 types. One is the durable type or chronic type, and this is the type of mechanical support or pump that you can go home with. The other is temporary, the kind that if you get really sick in the hospital, you're waiting on the transplant list and you're dying, you put it in and it can save your life. And one of those, probably the highest level of support in that category is ECMO, extracorporeal membrane oxygenation. That's really full support, supporting the heart and the lungs. And I mention that because last year during the pandemic, there were some people, initially the results weren't that great, but we used it in young patients who would otherwise definitely die. We were able to save some lives with it. And it just sort of brought the technology front and center because people who were not aware of it now realize that this is a therapy that can be used, not just during the pandemic, obviously, but for anyone who's dying or on the waiting list that is really suffering. We have used ECMO for patients on the heart transplant waiting list that come in and decompensate and need something urgent. And so we've used that as a bridge to the transplant. We've supported patients in the hospital anywhere from a few days to a few weeks on ECMO while awaiting the transplant and then successfully transplant them. Recently, we had a busy period where thankfully we were able to do 6 transplants in 6 weeks over the last couple of months. Some of them, actually 2 of them came off ECMO to transplant. So we really we feel so privileged to be able to have this scope of services to offer to the heart failure population because it's a very large population of patients here in the United States. The numbers of patients who might develop COVID-related heart disease that's significant is around the order of 20% or so. And so we're just not even a year since the height of the pandemic. I suspect that, we will see the effects of what COVID does, in these cardiac cases sometime over the next year or two. And I am just very, I'm really thrilled that our technology has advanced to a point where hopefully we can help them. I'd like to introduce our first panelist, Dr. Ova Kimyan. Welcome. Dr. Oksana Ova Kimyan is board certified in internal medicine, cardiovascular disease, and adult echocardiography. She has clinical interests in coronary and peripheral vascular disease, uh, cardiovascular disease in women, and sees patients in her Washington office. Dr. Ova Kimyan.
Thank you very much, Dr. Camacho. It was a great presentation. It sounds like you guys are busy there. That's great. As Dr. Camacho said, I'm an interventional cardiologist and consultative cardiologist out of Watchung, New Jersey. I practice at Morristown Medical Center and Somerset Medical Center, as well as periodically at New Brunswick Medical Center, so kind of everywhere. I have a special interest in cardiovascular disease in women. With not too many women in our field, so when we get to do what we do, we try to kind of help our own as much as possible. But I obviously specialize in all parts of cardiology. Today, I'm going to talk about cardiovascular disease and COVID-19 infection. As we've kind of all been through this year, if somebody was lucky enough not to notice, we've been in the pandemic for now pretty much a whole year. And it has changed all our lives quite significantly. We've been learning about this disease on a daily basis, and our understanding of it has changed quite dramatically since its original presentation about a year ago. At this point, we know that it mostly affects the lungs, and most people have symptoms of shortness of breath and present to the hospital, usually with symptoms of pneumonia, viral pneumonia. But there has been a substantial number of patients that have had cardiac involvement. And I've seen that in my office, especially after COVID-19 infections, as well as a lot of patients in the hospital. What we understand so far, virus has the ability to affect the heart directly, because it can actually invade the heart cells. It also can affect it indirectly by multiple ways. Most often we see in patients who are at hospital, and those tends to be a little more sicker patients who require oxygen, have other issues related to the COVID infection, which usually involves pneumonia. These people have a variety of issues. A lot of times they have heart involvement in the sense that it affects the heart muscle in a way that the heart muscle starts leaking an enzyme called troponin. That is a sign of a heart injury. And that injury does not necessarily mean somebody is having a heart attack. A lot of times that is not the case. It usually means that the heart is strained. And it could be strained from tiny little clots forming within the heart arteries, in the veins of the heart even. It could be related to the heart muscle directly being invaded by the virus, and also could be related to the people having significant lung issues from the infection, really bad pneumonia, and the right side of the heart, which pumps the blood into the lungs, getting really strained and enlarged and increasing the pressure there. All these issues can result in worse outcomes in people who have COVID-19 infection. And we even had people who can have sudden death related to the heart disease as acute presentation from their infection. People who have pre-existing heart conditions such as high blood pressure, coronary artery disease, heart failure, they were very well known to have worse outcomes when they have COVID-19 infection. And those people are the ones we call at a higher risk generally. So if you would get a COVID infection and you have those pre-existing conditions, you're at a higher risk of more things happening to your heart as you have it. Interestingly enough, in terms of what other things people have, while they're in a hospital, we've noticed a lot of irregularities of the heartbeat, especially slow heartbeat. It's been quite interesting. We've noticed a lot of that. And some people even required a support, like artificial ways of supporting their heart rate. But most often, I've noticed that it tends to resolve. What I've seen more in the office, in a lot of patients who've had COVID previously, maybe a few weeks ago, maybe a month ago, they start having a lot of palpitations. In conjunction with some residual shortness of breath, which tends to be for people who've had a little bit of worse case, and they've had maybe they need to be in a hospital, maybe need to be on oxygen, but they have a lot of palpitations. And from what I've done so far, when we put a monitor on them, a Holter monitor, to see what kind of irregular heartbeats they have, they tend to have mostly irregular heartbeats coming from top chambers, which tend to be less dangerous than the ones coming from bottom chambers. But they tend to be quite bothersome to patients and tend to elevate their heart rate. Sometimes we have to prescribe medications for time being, but what I've seen so far in anecdotal experience of taking care of a couple dozen patients, that they tend to resolve approximately 4 to 6 months later. So it seems to be probably related to kind of latent effects of the virus on the heart muscle. We have seen some patients who had really bad heart involvement. Those is actually not very common. They can develop a myocarditis where it inflames the heart muscle. They can develop what we call stress-induced cardiomyopathy, which we see in a variety of other acute illnesses, but it can happen with the COVID infection too, where heart muscle suddenly gets stunned and weakened in a very particular pattern. That usually resolves over time with medication support. I mean, most people completely recover from that over time, but in very few patients, it can result in very severe heart failure, weaken the heart muscle, and they can even have a really low blood pressure and require help of Dr. Camacho, in some cases. So, but thank God those cases are quite rare, and most people, if they have a severe infection, they tend to manifest in their, lungs being the more affected organ. From the heart standpoint, interestingly enough, we've noticed that during the time of the pandemic, especially the peak of pandemic in March and April in our parts of the country, we've noticed that there's been significant drop in patients who have heart attacks.
I can't unmute myself.
Surprisingly, you would think that the condition which tends to promote blood clotting would have more heart attacks, but surprisingly it did not affect that. It appears that COVID infection tends to increase risk of blood clots, mostly in the lungs and the legs. We call it venous thromboembolism. That is treated with blood thinners. But when it comes to the heart arteries, where we have a plaque rupture and cause a heart attack, those tend to somehow be less often. In large studies, both in the United States, United Kingdom, France, and all other European countries, we've noticed significant reduction in people come to the hospital with heart attacks in the range of 40 to 50% reduction. And there's a lot of theories behind that. Some of us believe that it's because people were afraid to come to the hospital and they may be having their events at home. But some believe that maybe less stress, being home, less pollution out there has resulted in a truly reduction of the myocardial infarction. We're noticing that now it's kind of coming back to its usual pattern. We have not really seen, because we thought that maybe if people coming in late, they'll come in a few months later really sick with that heart failure. But we haven't really seen too many of those patients. So again, it's all kind of evolving. We're still kind of getting data. We're still trying to understand the process. But it seems that it probably was related to partially people being afraid to come to hospital, but partially truly having a reduction in events, probably for all kinds of other reasons. You home, you're not going to work, you're getting less stress from that. Maybe it was effective. On the other hand, stress-induced cardiomyopathy, that condition where you have a sudden reduction in heart muscle function, which can happen with bad infection, with emotional stress. It's more common in women. That actually has gone up during the same period of time. And that includes people who have COVID and also people who did not have COVID. We just had a rise of that. And that could be on the other end, that some people had more stress. They were nervous about this and maybe lost a job and other emotional factors, and that increased their risk of that condition. And thank God that one tends to reverse itself. With medications, people do really, really, really well in comparison to heart attacks. So a very interesting pattern change of what kind of patients we see come to the hospital with different heart conditions. On a patient basis, we've been seeing a lot of patients post-COVID, as I said. So palpitations, I've seen probably the second common symptom. Most often, it's persistent shortness of breath. What the studies we've done, we're doing, obviously, when you come in after the event, you're still short of breath, we'll do ultrasound of the heart. Ultrasound of the heart is a moving pictures of the heart where we can assess the heart muscle function, assess any valvular problems, and see if there's any kind of residual issue left. We haven't really seen, I have really not seen too many patients who had any particular heart involvement a month or two after. It seems like when you do an ultrasound in these people, they have a normal heart function. And even the right side of the heart, which is the pumps into the lungs, which tends to be affected, it appears to be normal by the time they come to the office when they're overall feeling better. It seems like most of the shortness of breath appears to be related to persistent lung damage, and that can result in some of the fibrosis, meaning it can scar down and it could be permanent damage, and some of this residual inflammation, which over time may resolve. And most of us seeing that people are able to mostly come off oxygen if they had protracted course after hospitalization after a few months with help of the pulmonary doctors giving them proper treatment, mostly with inhalers and things like that. So from the heart standpoint, we're seeing less involvement as we thought initially we did. There were several studies initially when they did on athletes. Some of them might have seen them, studies using a technique called cardiac MRI. It is a very advanced imaging technique where we can see the heart beautifully. It's a very well done studies where we can see if there's any scar tissue, any inflammation in the heart muscle. And initially they athletes who are otherwise healthy, and a large number of them seem to have a lot of inflammation of heart muscle and fibrosis, which was very shocking. And a lot of those athletes didn't really have much symptoms. In subsequent studies in a similar population, we noticed that it's probably less often. It's not 70, 80% of patients had that kind of finding. So it appears to be more in the range of 10% or less, probably ultimately in terms of inflammation. The good news is most of these people appear to have normal heart function, and we really haven't had any patients suddenly die or something like unusual like that related to this. So we're hoping that these findings are more on the basis of microscopy, where it kind of affects the cells of the heart, but doesn't really relate into a real events like heart attacks or sudden death, which are the most worrisome to us. So even though heart involvement is quite common in terms of increase of heart enzymes when people are sick in a hospital with COVID infection, just like it would be with any other severe pulmonary infection or any other severe infection in hospital. We're not seeing that much prolonged effects, at least in this period of time. Obviously, we've had this pandemic for about only 1 year. Every day we're learning something more. Every day there is more studies. People are making new observations and trying to understand what to expect. And there's going to be a lot of new information. Things change all the time, and I may have another lecture like this next year, and it will be a whole new list of things we found and discovered with this disease. But so far, I'm quite hopeful that we haven't really seen too many significant involvement of the heart muscle, which persists and affects people's livelihood long term. So that's been pretty helpful. And another issue we had initially when this all started in March and April, that a lot of hospitals close their elective procedures. Even relatively urgent procedures have to be delayed, and that created a situation where we had to treat patients more medically, more of a kind of a 1960s style instead of our current 21st century treatments. And that has been an adjustment for us. But the good news is that we've kind of learned how to live with the infection, how to make hospitals safe for patients to come and have procedures done, how to open the labs. And that has made a big difference. The hospitals are very safe now. And if you feel that you have any symptoms concerning of a heart attack, and I'll go over those for you, you should not delay coming to the hospital by any means. The hospitals are safe. Everybody gets tested for COVID-19 infection when they come in. We try to put them mostly in a single bed so we don't have any interaction with patients. All the staff wears masks, gloves, whatever needed. Everybody takes extreme precautions to try to minimize any kind of spread in a hospital setting so we can take care of sick patients and hope not get them any sicker, obviously. In terms of symptoms when it comes to COVID-19 infection, there's really no specific symptom to separate your lung involvement from heart involvement, because it's all going to be the same. You're going to feel shortness of breath. Palpitations can be a very non-specific sign, and we've only been seeing it in about 7% of patients with COVID infection, including the ones who stay at home, who don't have severe infection. So it's not very common. Shortness of breath tends to be the most common symptom, as together with the cough and fever. In terms of particular involvement of the heart, mostly detected by blood work and EKG when you come to the hospital, and would only be seen in people who actually come to the hospital. So all this large number of patients who have not a severe infection, a mild infection, stay at home, really don't have any way of knowing if they have any mild heart damage or something of that sort, because that requires tests. And we try not to do those tests to limit exposure to the patient. So a lot of research, hopefully in the future, will be done to try to address that and try to understand what happens to these people who have mild infection. Like what kind of do they actually have any damage to the heart muscle on a microscopic level? Because when it comes to a major degree of dysfunction, they don't seem to have anything like that. So there's a lot of very interesting research is ongoing. Every other day there's a study coming out. So we're always on the lookout for any new studies and try to help out each other and share our knowledge and share our anecdotal experience of all the patients we take care of. But from my standpoint, I'm quite happy that 1 year we have followed this. It didn't seem to turn out into a major cardiac issue. We were able to kind of resort back to our relatively normal care for patients, able to do procedures they need, and care for those patients. And we're still learning on how to care for patients post-COVID. We test them as we are supposed to, but from my personal experience, most of these patients so far have been doing okay, and their symptoms tend to resolve over time without any particular damage, at least to most patients who had a mild or moderate infection. In terms of severe infections, those people have a lot of long-term lung damage. And that tends to be the main reason why they have longer term disability and not necessarily cardiac involvement. But overall, in my personal experience, the most thing I see is shortness of breath and palpitations. And it looks like most of it gets better over time, but time will tell as we have more to go. I think that will conclude at least my main presentation. If there's any questions at the end, I'll be happy to answer.
Thank you. Can you hear me?
Yes.
Okay, perfect. Sorry, I had a little audio issue. Dr. Marian Wassa, clinical cardiac electrophysiologist, is an advocate for cardiology patients to make sure they receive the best services, whether it's medications, convenient remote follow-ups, or the most advanced cardiac devices or procedures. She sees patients in her Eatontown office. Welcome, Dr. Wassa.
Thank you. Thank you so much for the introduction. Can you all hear me?
Yes, we can hear you.
Okay, perfect. So I'll get started talking about arrhythmias and electrical issues in the heart. But first of all, my name is Mariam Wasif. I'm an electrophysiologist and Monmouth heart specialist in Eatontown. And I'm here to talk about arrhythmias in general, but also briefly about atrial fibrillation, as it is the most common arrhythmia that patients present with. So my objectives for today, we want to briefly cover arrhythmia symptoms, what kind of tests physicians can order, risk factors for having arrhythmias, and simple preventative ways of preventing arrhythmias from coming back, if that's possible for the specific type of arrhythmia, and also basic treatments and therapies of what we can offer for patients with different arrhythmias. But before we get started at talking about arrhythmias, I wanted to go over simply, briefly, about what normal electrical conduction in the heart is, so we know what's abnormal. So normal electrical conduction, electricity starts from the top of the heart and it goes down in straight lines, just for simplicity, and activates the bottom two chambers of the heart, which are the workforce of the heart. And this is what normal conduction is. Anything outside of that realm in terms of extra heartbeats that come from the top or the bottom of the heart chambers, these are abnormal, and that's what we specialize in. Symptoms for arrhythmias, it's really important to know some of the signs and symptoms for arrhythmias to watch out for. And the more common symptom will be palpitations. And palpitations, everybody describes them differently. It's either fast heartbeats, slow heartbeats, or skipping of the heartbeats. Other patients also describe dizziness or lightheadedness. Some people feel their palpitations or their arrhythmias as chest discomfort, chest pain, or even just some shortness of breath. But last but not least is losing consciousness. That's a pretty big red flag that there might be an arrhythmia component to what made patients lose their consciousness or pass out, pretty much. Some of the tests that physicians can order for this, the most basic thing that everybody should deserve in terms of workup for an arrhythmia will be a basic electrocardiogram. And it's a quick snapshot to the electrical rhythm in the heart. And we sit down and go over what the patient is having and what their EKG looks like. But most of the time, because an EKG, it's one snapshot in time. A lot of time, arrhythmias come and go. And at the time that any patient comes into the office, usually the arrhythmia is not there, and we miss our window of opportunity. That's why we have a lot of different types of heart monitors that we can offer to patients. And what a heart monitor is, it's a sticker that goes on the chest over the heart area, and it's very similar to an EKG. So it's continuously recording the heart's electrical signals, and it's storing it. And this way, when it's worn by the patient for different variation of time, some people wear it for 3 days, a week, 2 weeks, or even longer, we can catch what the heart rhythm is that correlates to the time that the patient is having an arrhythmia, so we can tell what kind of an arrhythmia it's happening to help us treat it pretty much. The monitor has gotten so smart over time that they're very simple. They're a sticker patch that's the size of a Post-it note that goes on the chest, and it has a teeny tiny chip that's embedded within it, and it's continuously recording the electrical signal. It has no wires attached. People who have it on, they can shower, they can go about their day. We ask them not to do anything to suppress the arrhythmias because that's what we're looking for. We really want to bring on any arrhythmias, palpitations, to correlate it to what the EKGs or the heart signal looks like. But if all fails, we sometimes have to resort to an electrophysiology study. And we try to avoid it, but if we cannot find anything, that might be the route that we go for, which is it's a procedure where we go up into the heart with wires and take some electrical measurements, do some maneuvers to try to bring on arrhythmias. And this way we can see it and study it and do some maneuvers to see if it goes away. The next topic that I want to talk about is risk factors. Age is the biggest risk factor for developing arrhythmias, and it's just because of the nature as we get older, conduction system in the heart gets worn out, and we do see frequent bradyarrhythmias or slow heartbeats that are related to conduction disease that just happens because of natural aging of the conduction system. But any heart condition like having a heart attack in the past or having a thickened heart muscle, a lot of cardiac diseases, structural heart disease, can be a risk factor for having a lot of different types of arrhythmias. But other things that can provoke arrhythmias would be thyroid disease, some family history, because there are genetic disorders that are related to arrhythmias that run in families. But also electrolyte abnormalities. So if somebody has some kidney issues and their numbers are not in tip-top shape, all these things can trigger arrhythmias. For prevention of arrhythmias, unfortunately, it's not much because most type of arrhythmias, they're not affected by our diet and exercise, but good, healthy lifestyle, including a good diet and a workout regimen, it helps heart muscle to get conditioned, and it can prevent a lot of structural heart disease. It can prevent like heart attacks and things that can predispose into arrhythmias in the future. And then as far as treatments and therapies, a lot of time, depending on what type of arrhythmia patients are having, a lot of times if it's not a malignant arrhythmia and it has low risk and it's not really having a lot of symptoms and it's not bothersome to patients, we just watch it and we don't do anything about it as long as it's not, causing any heart muscle damage and not causing a lot of symptoms. Like if somebody has extra heartbeats coming from the top chamber of the heart, but the burden is so low, we just watch it usually over time. And I think if we can hold off on any medications, that's usually the best case of action, because any medication we use might have some side effects. But I usually do the least invasive approach. And if the arrhythmia is happening with a burden that's affecting quality of life, then we'll try to use some medications that have the least side effect profile, the least toxic side effect profile, and then titrate up from there. Unfortunately, some people have arrhythmias that happen despite of several medications and several classes of medications. And these patients, we can offer them more advanced therapies like ablative options. And it's most of the time, the route of an ablation would be the most definitive way of treating and getting rid of the arrhythmia and making sure that it doesn't come back for at least a long period of time. But it has risks, it has side effects and risks. They're usually well-tolerated procedures, and it's usually also a good alternative to medications if somebody doesn't want to be on medications for long periods of time. So in summary, I wanted to make sure that we go over some symptoms of what arrhythmias are, some of the risk factors, and what are the types of tests that we can do to figure out what type of arrhythmias patients are having, and also the treatment options. And I'll take any questions at the end if anybody wants to have any thoughts or any questions.
Can you hear me? Okay.
Yes.
Sorry, our final speaker is Dr. Tang, welcome Dr. Tang. She'll be discussing women's heart health today. Dr. Tang is a cardiologist and interventional cardiologist with special training in treating women's heart disease, lipid management, and complex coronary interventions. She sees her patients in her Edison office. Dr. Tang.
Hi, thank you. In women in cardiology, and I just noticed that our panel is full of women today, which is very rare, and that's really great for us. So, yay for us. I'm Delphine Tang. I practice both at Rahway Hospital and New Brunswick, and my office is in Edison. I do both general cardiology and interventional cardiology. Today, I want to talk to you about something I'm really passionate about, and that's heart disease in women. And the reason why I'm passionate about it is that it's the biggest health threat to women. It is the leading cause of death for women in the US, causing 1 in 3 deaths each year. In other words, about 1 woman dies almost every 80 seconds. It kills more women than all forms of cancer, and it can affect women at any age. We are currently in a battle, and in order to win, we need to increase awareness, and that's what I'm here to do. I want heart disease to be treated the same way that women know that they need to go get a mammogram or a pap smear, because about 80% of cardiovascular disease is preventable. In order for me to empower women out there to take their heart health seriously, we need to forget the myths. Heart disease does not only affect men, and it does not only affect the elderly. It affects both men, women, young or old. So what exactly is heart disease? It refers to several types of heart conditions, including heart rhythm problems, as discussed by my colleague, Dr. Wessoff. Includes atrial fibrillation, supraventricular tachycardias, congenital heart defects, heart problems that you're born with, heart valve disease, disease of the heart muscle, in other words, cardiomyopathy, heart infections, and most popular is coronary artery disease, disease of the blood vessels that supply the heart and can cause heart attacks if there are blockages. It is important that we recognize and understand the mechanisms that contribute to worsening risk factor profiles in women to reduce future cardiovascular disease, morbidity, and mortality. So let's talk about our traditional risk factors. This includes diabetes, which is a progressive disease in your body, which either your body doesn't make enough or doesn't respond to proper insulin. It's important to know that about 70% of people with diabetes die of some form of cardiovascular disease. Diabetes can lower your good cholesterol, known as your HDL, or your bad, and raises your bad cholesterol, known as your LDL, and also raises triglyceride levels, which also further increases your risk. It's also associated with high blood pressure and being overweight. Another risk factor, as discussed, is hypertension. So if you're finding if your blood pressure is greater than 130/80, we need to discuss ways to decrease it and improve it. High cholesterol levels. Physical inactivity increases both heart disease and stroke risk. Being overweight, and smoking. It's the single most preventable risk factor. So if you're smoking, I would recommend stopping, and if you haven't started, don't. There are other female unique or female specific non-traditional risk factors that have been emerging. Specifically, if you find that you've had preterm delivery, women who've delivered babies prior to 37 weeks or even before 34 weeks have greater risk of cardiovascular disease. Any type of hypertension during pregnancy, including hypertension before you were pregnant, gestational hypertension, and most severe is preeclampsia. Preeclampsia carries a risk despite the resolution after delivery. These women are 9 times more likely to have heart disease. They have increased long-term risk of cardiovascular disease, renal disorders, diabetes, and these risks are increased with the more severe type of preeclampsia you have during pregnancy. Gestational diabetes increases risk of diabetes later on. So screening right after you give birth, 4 to 12 weeks postpartum is important, and every 1 to 3 years after that. Autoimmune diseases is not only unique in women, but autoimmune diseases like rheumatoid arthritis and lupus tend to be more prevalent in women. These are diseases in which the immune responsive antigens result in damage or dysfunction of tissues, blood vessels, and can affect multi-organs and systems. including your heart. Breast cancer treatments. Ionizing radiation from your radiation therapy can increase risk for ischemic heart disease, as well as valvular disease and heart muscle. Chemotherapy can cause cardiotoxicity to your heart and can cause damage to your heart muscle as well. We have found that women who have postmenopausal women tend to have more heart disease, and women that have premature menopause also have increased risk. These risks include increasing the fat on your body. It causes increased insulin resistance, which causes diabetes. Your lipid profile tends to be puts you more at risk for coronary artery disease. And even if you are normal, have normal numbers before menopause, these numbers can change after menopause. Your blood pressure can increase, the LDL or bad cholesterol can increase. So these can change, and you need to have these monitored after menopause. Something else that is not women unique, but more female specific is depression, stress, anxiety. Women tend to deal with more stress related disorders than men. It's been increasingly recognized that this has been a risk factor for development of coronary artery disease. Even modest increase in anxiety levels have been associated with greater cardiovascular risk. And this seems to be affecting a lot of our young women. We've had developments in a lot of our medications and techniques in how we can improve heart disease. And cardiovascular mortality has declined in the US over the years, but it hasn't specifically declined in the young women population. And the question is this associated with the rates of depression that we're seeing in the young women? I think that especially now during COVID, I've been seeing a lot of patients in my office that have been complaining that they're having a lot of stress at home, especially women dealing with childcare and homeschooling. It's something that's been really troubling for them. And we have to remember that there's a mind, body, and heart connection. And we need to find ways to deal with the stress so that we can alleviate some of these risk factors. Engaging people through media like this, networks like this, Zoom, WebEx, talking to other people, and trying to get physical activity. Positive outlooks themselves can, higher levels of optimism have been associated with 35% decrease in heart events. Practice mindfulness or seek professional help. These are very important to decrease your risk factors. So now that we know the risk factors, I think that something that is near to me is that I'm an interventional cardiologist. I think that we need to know the warning signs of a heart attack. And signs and symptoms of certain disease can be different in men and women. And it's important to recognize symptoms early. Women tend to present later, and that can lead to worse outcomes, especially seen now during COVID. As my colleague had mentioned earlier, we haven't seen as many heart attacks come to the hospital, but the ones that I have seen, I've seen complications that we haven't seen in a long time, and people are presenting later. This awareness session is not only for our patients, but for medical professionals, and we need to be aware of some of the symptoms because they're not always the most common ones. Women tend to have they get delayed care, and just because their symptoms, they don't come to the hospital right away, their symptoms present a little differently. So let's start recognizing them. First and foremost, chest pain is still the most common symptom in men and women, but women may say that it's just a dull pain. It can vary in different locations. It could be in their jaw, in their neck, their arm, their shoulder, their back. But this might not be the most prominent. Other women might just say, I have a little bit more fatigue, shortness of breath, nausea, indigestion is very common, dizziness, cold sweats. And because these symptoms are more subtle and they're not really that sudden onset, elephant on my chest, people squeezing their chest like on TV, they may ignore them or attribute them to flu or indigestion or just aches of pains of getting older. So we need to be more aware and just seek professional help if this is something that that has been bothering you. So things that you should know is that you should start being screened by the age of 20. Seeds of cardiovascular disease are planted early, but it may not manifest until something bad happens like a heart attack. But the disease has already started in your body. Know your numbers, seek your doctor early, know your cholesterol, know your blood sugar, know your blood pressure, know your family history, talk to your family. When I mean family history, this is your immediate family members, your mother, your father, siblings, especially if someone's had a heart attack or a stroke before the age of 55 in a male and before the age of 65 for a female. Maintain a healthy body weight and diet. Diet meaning unprocessed foods, vegetables, healthy fats, including avocados, walnuts, almonds, salmon for the omega-3. And I don't mean supplements, I mean actually consuming the actual fish products and complex carbs. Exercise regularly and don't start smoking or avoid smoking. Speak up and talk to your doctor. If you've ever had any of these pregnancy-related complications, or you've been identified as having a heart condition prior to being pregnant, you might want to speak to your cardiologist and see what your risks are. Women tend not to prioritize their health, but they tend to be caregivers. And I think that you can't be a good caregiver if you haven't taken care of yourself just yet. Why is heart disease especially important now? As discussed, we have seen our patients with heart issues our patients with heart issues that contract COVID have had worse outcomes, unfortunately. So women, I empower you to take control of your heart health, be your own advocate, and ask questions. Thank you.
Thank you so much. Thank you to all the panelists. I checked the chat box and I don't see any questions. If anyone has any questions, please don't hesitate to type them in the chat box. In the meantime, I'd just like to pose a general question to the panelists. Obviously, one of the real concerns during the height of the pandemic and afterwards was that patients were not seeking medical care because they were afraid to come into the hospitals. Now, I can see that being justified in a lot of cases. As you know, many of our hospitals were just overflowing with COVID patients, and the capacity was reached both in New York, New Jersey, and the surrounding states. Since then, or actually during the pandemic, did you notice a marked decrease in your in patients that came to seek care in your practices? Since then, I know across the RWJ Barnabas Health System, we've made it pretty clear that we, assure a COVID-free environment for treatment when you seek care at any of our system hospitals. But have you noticed that with this kind of approach that you're trying to convince patients that it's okay to come in, that you are seeing your practices build up again with patients seeking the care that they need? And what effect has telehealth had for you? Because I can tell you as a surgeon, we rarely used, if any, telehealth prior to COVID. And now we found it quite an appropriate way to follow up on patients, in certain instances. So I'd be curious to know how telehealth has factored into your practices now.
So I can chip in. For us, especially in electrophysiology, telemedicine has been of a great help because also with the developing technology of the different devices, we were able to do a lot of remote checks by which the patients who have pacemakers and defibrillators, we get reports of their devices. If there's any issues, or even if there's no issues, we can get physical data that's downloaded to the office remotely. And then we look over it if there's any issues, or even if there's no issues, we can talk to the patients on the phone or with video, see how well they're doing and communicate that information. So for us, it's actually been a big step forward of decreasing the number of unnecessary visits, especially in the middle of a pandemic. It's been great.
Sorry, for my office volume, I feel like patients are still coming in, especially if they're following up. I think earlier on, maybe in the earlier months of COVID, it was not really the case. We do telehealth visits, and that has, again, been very helpful. However, I feel like if you have a very severe acute condition, sometimes still seeing the patient in person is a little bit more helpful for management wise. But if it's kind of a follow-up, telehealth has been extremely helpful. As far as hospital volume and procedure wise, volume has come down. I think patients are still afraid to go to the hospital. We have taken precautions in the hospital. Like you said, everyone is getting screened prior to going into the lab. But I think there's still a large fear out there given the recent spike in the past month or so. So I have noticed that patients are still scared to go to the hospital, and when advised, especially when calling into the office, that they have chest pain and we're not here to see them right away, it's hard to tell patients to go to the hospital. So that's been a little bit difficult. And it's not something that you can really just telehealth over the phone.
Mhm.
Yeah, in our practice, we used a lot of telehealth initially in March and April, but at least in our population, people don't seem to like it as much and they prefer to come to the office. So at this point, I literally have no telehealth. It's all in-person appointments. We take all precautions in the office. We don't have people waiting in the office. I'm sure most of you doing the same thing. They wait in the car, they're checking in, they're wearing a mask. We clean each room after each patient. But I've noticed that the telehealth has not really continued to be a thing after the initial spike in March and April, where it was 100% telehealth. I do agree with Dr. Tang that our volumes are still down, but a period over the summer where people started to come back in the hospital, they were less afraid, but now they're again having this issue that they're trying to avoid the hospitals. But they're not avoiding to come into the office though. Our office has been as busy as ever. We haven't really had issues people being afraid to come to the office. So at least that way we can, assure proper care. But the hospital wise, yes, I have patients who want to get out of hospital as soon as possible. They don't want to stay, they want to get tests. That continues to be an issue.
Yeah, Dr. Ovakimian, I agree with you. There are patients that feel much more comfortable coming to the office, and I can understand why they wouldn't want to come to the hospice. Now, what we do though is that, as a system, we really do assure, like I said, the best COVID-free environment, but still, I can understand why patients are hesitant. I think that, we'll have to see how it plays out in the next few months. Hope that the numbers will go down, the vaccinations will have an effect, and that people will feel more comfortable coming for the care they need. It's interesting, though, that when they are not comfortable, that telehealth has been a great way to at least connect with them in some way. I know that during the height of the pandemic in March and April, people died from heart attacks and aortic dissections at home because they just didn't want to come in. So if we can find some way to connect with them that's not in person, to at least make a plea to urge them to come in and say, look, you need an urgent intervention and we have a way to give you a COVID-free pathway, that maybe we can, just save some more lives until people become more comfortable. So I really see telehealth as a great alternative for people who just refuse to seek care because they're afraid. In the cases concerning COVID-related issues. Why do any of our panelists have any final comments? I don't see any questions in the chat.
I think, Dr. Camacho, there's a couple questions I saw come in. I think only the host maybe might be able to see. I saw one of them was asking if you have high blood pressure and it's currently being controlled by medication right now, are you still at a higher risk related to COVID if your high blood pressure is controlled through medication?
I guess it will be towards me.
Yeah.
Yes, technically you're still at higher risk. We don't really understand exactly why, but some of it could be related to just underlying physiology of people who have higher blood pressure. But technically carrying diagnosis of high blood pressure, even if it's well controlled, it still elevates your risk of complications from COVID-19 infection.
Okay. Another one that I saw come in was someone was asking, is the nature of the disease, I think he's asking if is the nature of cardiovascular disease, has it been changing? He was saying like our climate, or is this more of the same, learning from all of the history we have on record? So I think he was just looking to see if cardiovascular disease has changed and evolved over time. That was...
That's
That's
a
a, that's a
existential
tough
question.
question. So
Yeah.
I don't know if we have
I,
the answer.
I mean, it's like anything else, it's always changing. All the studies we have now, they do start involving women. Studies back in the day really had no women at all. So all the data we have from 10 plus years ago was all on men. So we do have a lot more ability to test for things. We have more technology, and what we can do today, 30 years ago, would be a sci-fi movie. And it involves pretty much entire cardiology. So does a disease evolve, or the techniques to find it evolve? It's hard to tell. But we know for sure is that our diet is getting worse. More people are more obese. There's more hypertension, more diabetes. So that the risk factors are getting worse. So we're seeing more heart disease generally. We treat it better. We can address it better. But I am personally seeing a lot more people with a lot more coronary disease, a lot more plaque in the arteries everywhere in the body than I think our colleagues used to see before. Could it be because we test more, we can find those things better, and we have actual ways to treat it now, which in the past we really didn't, possible, or is it disease evolving? It's probably both.
That's great. And it kind of goes into another question that we got, just a couple more, and I know we have to wrap up soon, but someone wanted to know if we could just talk about some specific good or poor foods for cardiovascular health. They're just looking to hear some specific things to maybe consume or not consume.
I would consume more fruits, vegetables, lean meats, avoid red meats, more like a Mediterranean diet. I would white rice, pastas, use whole grains. That would be a better diet.
Okay. And then just one more, somebody asked specifically which symptoms would indicate the use of an MOCT test, and what would the results of the test lead to? Would that be a pacemaker? That was the question.
Sorry, say that again.
It says, which symptoms would indicate the use of an MOCT test, and what would the results of the test lead to? Would it be a pacemaker?
So it's the MCOT. It's one type of the heart monitor. So it really depends on. It can pick up a lot of different things. So it can pick up slow heartbeats, which will be like heart block or bradycardia. That's the fancy word for saying slow heartbeats. And these are generally treated by looking at what's causing them and trying to remove the element that's causing slow heartbeats. And it goes also for fast heartbeats. So it can pick up fast heartbeats or tachyarrhythmias, which is the fancy term for saying just fast heartbeats or fast arrhythmia. And these are treated either with medications to slow down the heartbeats or to maintain normal rhythm. Or depending on the type of arrhythmia, the specific fast type of arrhythmia, an ablation can be offered. So it can pick up a whole lot of different rhythms, and it's not usually just one treatment option for an abnormal result on an MCOT. So it depends on what was the result. Like we have to look at it specifically and evaluate it first before saying, oh, you need a pacemaker, you need an anti-arrhythmic medicine, or you need an ablation. So yeah, depending on the specific results of that.
Okay, great. And then this will be our final question before we wrap up, because I know you guys have to get back to your patients. But someone was asking about they said they were hospitalized a few years ago with viral meningitis, and while they were there, were diagnosed with AFib, and they were given blood thinners, and they monitored their heart through a portable device, and have not had any episodes of AFib since then. And they were wondering, they've heard that sometimes that can occur due to, infections or medications. And since they haven't had AFib since then, they want to know, how can they verify that they that maybe this was like a one-time episode for them. They were wanting to get a Holter device, but the doctor wanted to insert something in their chest for a 1-year period. And, they want to know, are there any other options for that?
So it depends on the clinical history. If it sounds like and it's also not just about what caused the AFib, but also we look at the patient overall's risk profile. So we look at the risk factors for having blood clots. So depending on their other comorbidities, to see if they have history of heart failure, hypertension, diabetes, if they've ever had a stroke. It really is patient dependent, the decision whether or not to continue the blood thinners despite of taking care of the issue that was provoking the atrial fibrillation. But to be honest with you, my personal preference is that a stroke, it's a pretty devastating thing. And it's most of the time it's not reversible. It's nothing that I can give you a medication and it will magically go away unless if it was treated early on and then picked up in the hospital. But if it's really not treated within a certain window, it can be devastating. So the decision of stopping the blood thinners has to be taken very, very carefully. And most of the time, I would recommend to get a longer type of monitor, because even though that the atrial fibrillation was provoked by something, it means that you still have the electroanatomic changes that make the patient prone to have recurrent AFib. So it's not a simple decision, unfortunately, and a lot has to be taken in consideration in terms of the patient's risk profile, or what's their tendency to develop blood clots or to have recurrent atrial fibrillation. So I would agree.
Okay, great, thank you. And then this is not a question, but just wanted to put this out there. Somebody wrote, no questions, but thank you very much for an informative presentation. It's very inspiring to see a strong panel of women in cardiovascular medicine. So I thought that would be a great way to end, and it really is, and we appreciate your time. And if there's more questions, I believe afterwards you'll be getting a survey from this WebEx, so you can always send the questions in, and we can have our doctor panelists respond to those also. But thank you all. This was really great and really interesting, and I appreciate all of your time.
Yeah, thank you.
Absolutely. I just wanted
Thank
to
you.
note that having 2 interventional cardiologists, an electrophysiologist, and a cardiac surgeon, all female, it's a sci-fi movie.
It is.
It is.
It's amazing.
It's a sign of the times.
Yes, and
Bye,
thank
thank
you.
you.
Thank you so much.
And thanks, Dr. Camacho, for leading us on this too. I appreciate it.
My pleasure.
All
Thank
right.
you.
Thank you.
Thank you all.
Take care.
Okay. Bye.